Right. So my name is Whip Lamba. I'm a psychiatrist in Toronto. I do a lot of addiction medicine, some psychotherapy, and I'm presenting today with Dr. Primo.
I have a mic.
Perfect. Good.
I'm Valor Primo. I'm a general psychiatrist in North Bay, Ontario, focusing on addiction psychiatry and early intervention for psychosis. Thank you for joining us today.
Great. It's really important for me to make these two sessions experiential for you, for those of you that are in the audience. I'm going to talk a bit about psychotherapy, talk a bit about ACT, then we're going to play a game, and then we're going to do the same thing for DBT, but Val will be talking about DBT, and then we'll play a game there as well. So this is the agenda that we have today. We'll try to stick to the time as much and as quickly as possible. And so, yeah, I just don't have my glasses, so I might be looking back and forth. But it's basically going to be teach about ACT, then do a little demonstration kind of thing, and then you try out the demonstration yourself. And then for the DBT, learn a bit about DBT, and then you're going to try to do what we call a behavior chain analysis. And I know we're aiming a little bit high with the behavior chain analysis, but for every psychotherapy skill that I've done, I've always followed a rigid structure to start. I do it pretty badly to practice at first, and then little by little I get better. And then for patients I have that can't get access to these treatments, I ask for permission and I try to sprinkle it into my encounters there as well. Because all of your healthcare providers, you all have patients that you see regularly, that trust you, that you really care for them. And because it takes so long to get into these evidence-based programs, a little bit of those micro interactions could have value that you do yourself with them. So let's just sort of keep going. So you may or may not know there's different waves of psychotherapy after the whole Freudian, those kinds of things. And so in the 40s, 50s, 60s, there was the first wave psychotherapy. This was all about behaviorism. So there was Skinner with the conditioning, and I'm drawing a bit of a blank right now. But then there's Skinner with the, is it with the bell? Or Pavlov's with the bell, and then he links to the bell. And Bandura is the one where you see it, you watch a video, you sort of learn it that way. You learn by emulation and imitation. And they believe, the behavioralists believed, it doesn't really matter what the person's thinking. It matters is what the person is doing, and that's what they were trying to shift and change. Then there came the second wave psychotherapy, I think, therefore I am. Most of you probably know Aaron Beck. Some of you may or may not know Albert Ellis. They both developed a psychotherapy that was very much like CBT, emotional awareness, emotional therapy, but Aaron Beck was able to protocolize it, get the RCTs done, and CBT was the one that spread. But that was, I think, therefore I am. And then there's the third wave psychotherapies that came after that. So this is like acceptance commitment therapy, dialectical behavior therapy, mindfulness-based stress reduction. And why do I have the cartoon up there that I have? It's because the people that developed these therapies, Marsha Linehan, Stephen Hayes, John Kabat-Zinn, they all went somewhere, Southish Asia. They stayed at some kind of a temple, monastery, ashram, somewhere for a period of time. They fully embodied and developed those practices that were there. And they took the component that spoke to them, and then they brought it back and they embedded it in their psychotherapy. And the reason I show that, this is from a famous Indian myth or epic tale, the Mahabharata. This is where there's the hero Krishna is there, and he has to decide, do I destroy my cousins or psychological demons, however you look at it, but these are a part of me, and live the path of good, or do I not destroy my cousins or kill my cousins and stuff? And his guide, Krishna, for Arjun was meditate. My dad always used to say it when I was a kid. I was like, why is he telling me to meditate? I don't get it. But supposedly some of these therapies are slowly coming back. And with these third wave therapies, they all have this thing where you're not the body, you're not the mind, you're not your behavior, you're something separate. You're an observer of some kind in some way. And there's something about that separateness that allows us to work with the problem in a very different way than when you're feeling, living and breathing those emotions as they come and go. Data is coming out for the third wave psychotherapies for addiction. And so I know even if you don't have borderline personality disorder, but if you go through dialectical behavior skills training, your depression, anxiety symptoms get better, and your substance use goes down. And so the data is coming for that. I always share this cartoon. I don't know why I like sharing this cartoon. This has the three areas of the brain that are responsible, they say, for addiction. They talk about the craving urge to use, which is that nucleus accumbens, that ventral tegmental area pathway. That's where the dopamine cells fire in those cartoons. There's that amygdala, that fear, that withdrawal, perioctal gray when you look at opiate withdrawal, and then there's the anticipation piece, and there's the A process, B process, A process, B process, A process reward. B process is the bad feeling after you're done using. When you start using, A process is amazing, feels great. B process is almost non-existent. After a while, the A process is smaller, smaller, smaller. B process is bigger, 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 and sometimes people say stress can make that switch. Sometimes people say that heavy use can make that switch. So what does the third wave therapies do? They become the observer. So all of a sudden you're in a place where you're not there with that A process, B process, A process, B process. You're noticing the A process and B process. You're noticing you're sweating, you're noticing you're getting those hot colds, you notice you're getting that runny nose. And even though it's debilitating and stressful and horrible, you might have suicidal thoughts, you're doing it as an observer. And then the experience is a little bit different. And then the data is coming as well for that as well, and you have access to the slide decks as well, and you can go through the paper to see the different ones that are there. So Stephen Hayes is the one that developed acceptance commitment therapy, and a few years back I went to my favorite psychotherapy conference. It was the Evolution of Psychotherapy, and there they have about 10,000 regulated healthcare professionals that come there. And during those sessions, they have these workshops where you watch the therapist do therapy. He had one session that was there where he was with Bruce Burns, the person who wrote that Feeling Good handbook. And it was so interesting watching them together because Bruce Burns made the comment that, when you look at his book, it was a reading level of like grade 3. When you look at Stephen Hayes' writing, it's like a reading level of grade 11, I think it's like grade 20, 21, because he's very, very educated. But he's done tons of research on this, tons of studies on this, and you can almost tell that his mind is going with this as well. And for him, with all the work he's done with acceptance commitment therapy, he says that acceptance and commitment therapy assumes that the psychological processes of a normal human mind are often destructive and create a psychological suffering for us all, sooner or later. And the treatment focuses on acceptance of these unwanted private experiences, which are out of our personal control, so that acceptance piece, and then that commitment and action towards living a valued life. It's based on this functional contextualism plus relational frame theory, so just understanding yourself in terms of its context and how you interact with others. The big goal is creating that psychological flexibility. And we all know there's certain things in our own life or certain things in our patients' lives when they're depressed, their mind gets stuck. The world is not safe. I can't trust anyone. I can't connect. Why would I leave? And then they get stuck in this pattern of thinking and sometimes in this pattern of behavior. And the whole idea about acceptance commitment therapy is to create that flexibility. You create a space where that flexibility can be created. The therapy principles are empathy, self-compassion, collaborative stance, self-disclosure. And the way that he does it, there's 6 core components, and he tries to get people to shift over. So when we're sort of stuck, there's that internal experience. So the internal experience is the experiential avoidance. So anything that's uncomfortable, we don't go towards it. Cognitive fusion, the thoughts are stuck in terms of how we believe. And then also we attach ourselves to the conceptualized self. So what is that? That is my thoughts, that is my behavior, that is my emotions, that is who I am. And this is the internal process that acceptance commitment therapy wants to help us accept. And then the other part that when we're stuck is that we get stuck in terms of the conceptualized past and feared future. We also aren't connected to our values in terms of the way we look at ourselves and the way we look at the world. And then also there's not that commitment to action in a way that matches our values. And so when you go through this process, you try to create this acceptance of how the person is, who they are. You have this diffusion where there's this separateness from the thoughts. You just sort of notice those thoughts and then see if there's a way to work there. And it's not necessarily about changing the thoughts, it's about that diffusion, that separation from it as well. And then the other part is the self as a context. So, I'm not the body, I'm not the mind, although he uses different language and stuff about it. The other part is the moving towards. So that is the connecting with the present moment, being aware of our values, and then the committed action that fits with our values. So what was the drill that I saw Stephen Hayes do at that conference? It was wild, I tell you. So what he did was he would have somebody come up he would have somebody come up, and this was a licensed psychotherapist, and they would sit there, and he's like, this drill, it's not for you, it's for me to practice being a therapist. You can come up there, talk about anything that you like, anything that you're struggling with, anything that's not going well. And then what he had behind the practice patient was a PowerPoint deck where random words would come up. It'd be like context itself. It would be acceptance. It would be this. And then he did this twice, this 20-minute drill where he would just try to make a statement that fits along any of these 6 elements where you move from the stuck self to the detached, flexible self. And every time it brought out these emotions and stuff. So we're going to try this quick. We're going to demonstrate with myself and Val. And every time I do this, I tell myself that it's good for trainees to see someone do it badly, because then they can do it and then they'll get better and all that stuff. So let me just pull up this thing so I don't have to stare back at the screen. Oh, you were going to go here, right? Okay. So we're going to try this out. And what I'm going to do, actually, if we can just move this back to the circle. So this is the circle that we had there, contact with the moment. And then what I did was, just to make it easier for me, is that I have this here. So this is the inward side here, around the acceptance, diffusion, self as context. This is the outward, contact with the present moment, values, connected action. One metaphor that Hayes liked to use is that the inward is like embracing that, whatever that demon, whatever that stuff is there inside, and the other part is moving forward. So we're going to try this game, and then you're going to try this game. And when you try it, we'll probably have the pretend patient be on this side, the therapist would be on this side. So are we going to try this out? We're going to try this out?
Sounds good to me.
Okay, let's see how this goes. Like, I'm really good at this. Is like okay, let's go. All right.
Well, I've been really wanting to talk to you about how much I want to declutter my house lately. So that's been a topic of interest. I've been wanting to ask him for a while. So
right now your house it's really cluttered. When you look around, you see all these things around you.
Yeah, there's just a lot, and sometimes it just feels like it's cluttering my mind because there's so many things in my house. So I'm trying to find a way to kind of trim down.
You really want to have a clear mind, and if you have a clear place around you, then those two things really do connect.
Yeah, exactly.
Yeah, and part of you is thinking about, how do I get this clear mind, and part of it is going to be starting the process of decluttering.
Yeah, I'm thinking too, the more that I declutter, the more I'll feel better, and the more I feel better, the more I'll want to declutter some more.
So it's also one of those things, when you're there in that clutter, it feels like you're not in a good place.
Yeah,
right?
yeah.
In some kind of way. And I wonder, what would it be like for you just to see yourself there, but so not necessarily feel that uncomfortableness around, but just sort of see yourself there looking at that decluttered, but not fully feeling.
So, like looking at it if it wasn't cluttered?
No, so you're there.
Yep.
The place is cluttered,
Okay.
and you're feeling a certain way.
I'm feeling pretty heavy, yeah.
Yeah, and just imagine you're sort of like watching yourself, almost like a movie or something, and you're like watching that person in that house. What would that be like, seeing you in that house?
I would see somebody that's pretty, probably a bit disorganized in the morning, trying to find her stuff to get out the door.
Yeah, but no, it's sort of interesting that, when you did that there, you're sort of smiling a little bit when you were doing that, whereas when you had the clutter, your body was all like different. What's your mind telling you right now?
That this was a bad idea.
Yeah.
Well, then I want to put that into action. I want to actually make a plan to try to, make my habits a bit better and have a more organized house so that it's healthier for me and I feel more at peace.
You feel more at peace that way, and it's almost like you sort of see that. It's almost like when you talk about it in that distant way, it's like you're sort of clear where you want to go with this, what you want to do.
Yeah, I don't really have a plan just yet. I just know that it's probably not going to happen overnight, right? So I'm going to have to do it incrementally, but I haven't really kind of picked how to start. It's kind of hard, right? It's like an iceberg, right? Like it's like you keep digging and there's more. So
yeah, and right now, what are you noticing in you at all?
Well, when I talk about it, it's a bit anxiety provoking, but at the same time, it feels good to talk about it in front of a bunch of people.
Yeah, it's almost like you're getting better. They want to get better at being a therapist. You want to get better at being a therapist.
I feel they're very supportive too. So
They're very supportive in there. And so, what kinds of things do you think you might do to try to create that decluttered piece for yourself?
I think maybe just try to have a game plan, right? Maybe like kind of figure out what the first step would be and try to divide it in smaller tasks because that might be a bit more achievable. So
A little bit more achievable. Um, and for you, yeah, no, it just sounds like you really want to make this shift. You just haven't started yet in some way.
or I've started and I've kind of stopped, right? It's like you do a little bit and then you feel a bit better, then you kind of pause it, then it gets back to being cluttered again. So
Yeah. And when you talk about the cluttered, what's there that goes on your mind every time you say the cluttered part?
yeah, like I said, heaviness, like it just feels like kind of like a burden, something that, because like I was thinking, like if I ever wanted to move somewhere else, like I have all this stuff that I have to carry with me. It feels heavy, like a lot of baggage.
It's like there's a lot of items, like physical items, and
Yes.
then there's also this heaviness that comes in you when you think about
Yes.
it, right? And it sounds like the only way really to leave is if you bring everything with you.
Well, I would hope I wouldn't have to do that, but right now I would have to, right? So yeah.
So you don't want to be separate from a lot of those things and
Mhm.
those thoughts.
Right.
So maybe I'll just sort of do a timeout and pause a
All
bit.
right.
So So I'm not a pro at the ACT therapy, but I do want people to play this game. And normally when we do the game, I would coach Val that, this is not for you. This is for me to practice being a therapist. This is not meant to be therapeutic or any of that kind of thing. And then for those of you that do dive a little bit deeper into ACT, you'll find that they have very structured processes that help people move from one area to another. The part that I want you to start thinking about is what can happen interactionally. So we're going to do about 5-7 minutes. We're going to have you pair up, and one person is going to be the therapist, and you're going to try to you can almost pick any, or you can go in a circle, and the person can talk about anything. It doesn't have to be something you're uncomfortable with. It could be, I went to the store today, right? Or I had this for breakfast, or I only got the lasagna, but I didn't get the chicken, and then just see what the comments are that come up. Does that make sense a little bit? Yeah, go ahead. Yeah, it wasn't clear. Yeah,
Whip, do you want to come back here since they're going to be still recording at this point?
yeah. So, so the contact in the present moment could be something more like what are you sort of noticing now? What's happening now? And part of it is yeah, just around what's happening here in your body. So the person might be talking about the heaviness, might talk about that. Well, what are you noticing now? What are you feeling now? What are you experiencing now? Values. I think I did a little bit of that. I think that's a bit easier for me with motivational interviewing. Around, you really want to clear your mind. You really want to have a forward focus. You really like to be sort of present there. The committed action is sort of clear. The self as context, there's a couple of different ways to do it. I mean, some people sort of do metaphors or things like that. For me, I think for here, maybe something like you can even just sort of remind the person that they're separate a little bit from their thoughts. I'm not sure if this is the video stuff, but the diffusion would be around like what's the mind telling you. So they're talking about that, and then acceptance could be something like what would be a good line for a few people. Does anyone do ACT here at all or done ACT? Yeah. Does anyone have any thoughts for acceptance? What could be good for acceptance? Got you. So it's yeah. So that was good. So the example there was around what's it like to have those emotions? What would be like to make room and space for those emotions? Not that you have to change those emotions, what they are. And then as the person's sitting there, and then with that emotion, then to move to the other side. And maybe it's good to go in out if you're to try this out. And then let's see. Yeah, let's just sort of see how it goes. Yeah, we'll have to.
So maybe give it a few minutes for you guys to try it out. You can pick one piece of it. You don't have to do all of it, but just, oh, everybody's looking a little. Give it a try.
I feel like my voice is like shaking. It's a little. It's okay. Yeah. Maybe we should bring Mike over to. Okay. So do 30 more seconds. So 30 seconds, and then we'll just debrief as a group and move forward. So any comments on the drill or the exercise at all for anyone?
We'll stop now, everybody.
Just around, yeah, just probably around right getting to there.
Everybody's really having a good time. Guys, we're gonna come back. Woo! Everybody?
We did.
All right.
Maybe we'll just for like
Thank you.
maybe one or two comments from people around the game or the drill. I think one thing that's clear is probably good to have a list of questions for each item if we're going to be playing this. That part's very clear. Any other thoughts around this at all? That would be this. Was it interesting? Was it different? Was it? Yeah. There's. Yeah. So for with actual acceptance commitment therapy, it's a process, and a lot of my colleagues who do it very sort of structured with different sessions with different components. And so they give the framework, they give sort of each of these micro skills, but it's absolutely this ongoing process of accepting those demons and then moving towards the change. And the colleagues I have that use it, they use it almost as the transition out of clinic. So when people come in, they get screened, maybe we'll do DBT skills, maybe we'll get some psychiatric care, some behavior change, and then the acceptance commitment therapy we do to finish off the therapy. So there are specific things like that that would fit within the therapy itself. For here, we just wanted a mini game where we could think about how to practice this, and I think we're going to do a little bit of practice for the MI one a little bit later. Maybe what I'll do is for the sync drive, I'll just add a few references just around books that could be potentially helpful if you wanted the manual to do this fully. But absolutely, there is that goal of moving towards that committed action. It's just a different process, slightly nuanced than say MI or DBT to do that. So the question, yeah, okay. So maybe what we'll do, so just keep that concept in the back of your mind. Oh, was there another comment? Yeah.
Just a quick question about you mentioned at the beginning that sometimes you say to the patient that this is that you're doing this practice for yourself, that you're trying this out.
Oh, so this is like a therapist training drill.
Yeah.
Right? So I probably wouldn't do this with a patient. I might do it with a colleague. I might do it, but it's more about that practice of making some of those statements. That's just for this drill. That's not for the actual therapy and stuff. Yeah, that's exactly it. It's just I just wanted some sort of game. And I know for motivational interviewing, for example, a colleague of mine was just like, try making reflections with your friends and family just so you get comfortable doing it. It's very different than the healthcare interaction. So that was the game there. So we'll go through the DBT stuff and hopefully at least just that idea of that acceptance internally, moving outward, creating a space for that stays with you as you think about moving forward if that's something you want to explore. And I'll let Valerie talk about DBT. I think you're the director of the program where you are, right, for the program, yeah.
I am the clinical consultant for my psychotherapy team in North Bay. That is correct. So although I don't do the therapy directly, I do cover some of the groups sometimes, but I help them and support them in consultation. So at the same time, I wanted to put a plug for the fact that we just launched the Canadian Academy of Addiction Psychiatry. So if you are interested in seeing more cool concurrent disorder stuff happening with some formalized guidelines that I hope are going to come out and training and everything, definitely do email me and I can make sure to get you in touch with CAP. It's all fresh. We just launched a few months ago. For those of you who did not get the QR code at the beginning, you'll need it for the exercise for the behavioral chain analysis. We decided not to print to save on paper and trees. So if you can get the QR code on your phones, now is the time. All right. Go up in 5 seconds. So you've got 5 seconds left. Everybody good? So I wanted to talk a little bit about, and this laptop is really far, like watch me. I hope the recorders aren't going to get mad at me, but so I don't know if you know a little bit about DBT in terms of its history, but it started as being a form of CBT, and it was developed actually in the late 1970s. So it's been around for quite some time. I think when I ask often the trainees how long it's been out, they think like 90s or 80s at the earliest. It's been out for a while, but it hasn't been like disseminated until a bit later, especially in training programs. And it was developed by Marsha Linehan, and it was based on the biosocial theory of personality development. And the goal was to essentially assess people who are highly sensitive to their environment and highly reactive to events, what we call kind of that tsunami of emotion, and they were slow to return to baseline. So in case you don't know what the biosocial theory of personality development is, that's a very simplified version of it. So you basically have your own inheritability or genetics and your temperament, and then you couple that with an invalidating environment. And if you're also harder to rear as a child, then that environment is going to be even more challenging, and that results in pervasive emotional dysregulation. And unfortunately, borderline personality disorder is one disorder that comes with a lot of affective dysregulation. I would think that probably most people in this room know what BPD is, but I just thought I'd remind you that it is these three clusters of symptoms, and it's an enduring pattern over years that usually is not explained by any other disorders that can be quite impairing and disabling. Why do we talk about BPD? Is because DBT came out of working with individuals with BPD, and then we realized that a lot of other applications were really beneficial. So that's why we extended it to other types of disorders like substance use disorders. And these were some of the assumptions about BPD that were floating in society and among different practitioners. You may have heard some of those yourself, either from society or even sometimes staff that have been dealing with these patients, and they can be, I understand, challenging to work with, and sometimes that creates these assumptions. And so what Marsha noticed is that people were burning out trying to integrate these patients in CBT because these patients, if they've been very invalidating, are not going to do well with a very manualized CBT. Does anybody here follow a very manualized standardized CBT model anywhere here? All right. So it's very kind of organized, right? You've got your agenda, you've got your mood check, you're kind of going through your items. You know, you have to dedicate a certain amount of time. You don't have time to kind of go back and forth a lot, right? It's very regimented. And what she noticed is that individuals who are very dysregulated don't do well with that and find it very invalidating that essentially their concerns aren't being addressed or that they're not being listened to. And she noticed that the common denominator was that they were all raised in very invalidating environments. So she wondered what they would require in order to improve in therapy. And she looked at that unconditional acceptance and loving kindness. And that's what she started incorporating in DBT. So the first book that she released actually said cognitive behavioral treatment. So it was actually CBT, and then it became DBT later. And I already talked about this part, so I'll skip that. And basically, what is DBT? Is it's CBT. It added mindfulness, which was based on traditional Buddhist practices, and then it added that dialectical philosophy. So the idea that two things can exist at the same time. And the biggest dialectical that we see in patients with BPD, for example, is the wish to be alive and die at the same time, or the wish to improve and sabotage at the same time. So kind of learning that these two things can be true at the same time and trying to find a middle ground. So what is DBT? So it really looks at regulating emotions and behaviors. It was initially, like I said, created for BPD, but extended to a bunch of different disorders. It addresses the relationship between the individual and the environment. And the idea is essentially to recognize that people are doing the best that they can, but we can teach them more adaptive way of addressing their environment. So we're not saying that they're not trying. We're just saying that they have to try a bit harder or try different ways, right? And the idea of DBT is to create a life worth living, because a lot of patients that we see in our clinics are suffering deeply and they're stuck in a cycle of suffering. I have patients with chronic suicidal ideation that all they think about is essentially that suicidal ideation day in and day out. Well, that's no way to live, right? So I try to shift them from that position. And in DBT, the therapist, just like in CBT, is viewed as an ally. You want to try to have a conversation with them instead of having a bit more of a kind of adversarial relationship. It assumes, again, that people are doing the best that they can, but they either don't know the skills or haven't been positively reinforced with the right adaptive skills when they were younger. And then the therapist aim to accept and validate the feelings, at the same time letting them know that what they're doing is maladaptive and needs to improve. So these are the DBT assumptions. You'll see they're kind of the opposite of the earlier assumptions that I showed you. I won't read them all, but essentially it's the idea that people have to do better. They weren't essentially, like nobody asked to have this issue with affect dysregulation or struggle in life, but you are now in control of having to make those changes, and we'll support you doing those adaptive changes. And I wanted to just touch on the modules. We don't have time to go through all the modules, and some of you may have already seen this, but in substance use disorders and in chronic affect dysregulation, most of us don't have access to a full DBT program. I don't know about you guys, but North Bay is very far north, and we do not have a full DBT program, which is like 2 years of group therapy, individualized therapy, and phone coaching. We do not have access to that. But what we do have access to is a skills group, and that can be really, really helpful. Just learning the skills can be very helpful in starting the patients towards recovery, and that's what we think can be very effective in substance use disorders as well, based on the research. So how to learn DBT, if you are not very familiar with it and want to learn more, there's a lot of really cool books out there. These are some of the ones that Dr. Lamba and I use. But there's lots of different resources. So whatever works for you is great. You can attend a workshop, you can read a book, there's all kinds of virtual training available as well. And I know that Marsha Linehan also has her own institute and offers a lot of standardized training as well. So what I was hoping we could do today is do a behavior chain analysis, which is a technique that I use a lot in the context of substance use disorders. So we will not do it, won't do a demonstration because we don't have the time, because it can be a lengthy process, but we're going to make you practice one, and we will do one while you're doing one so that we can all share our observation afterwards. So anybody here that has done a chain analysis before? All right, cool. We've got some people that know. So you guys are going to be the experts in the room. So the way it works, I always tell people it's like a movie. So what you're trying to do is you're trying to recreate a movie in front of you, what happened. So whatever situation that your patient is puzzled about or that they wish had gone better, whether it's a recurrence, whether it's a situation that they place themselves in that was vulnerable, you ask them what the situation is, and you got to go back like if it was a movie and describe it like minute by minute or hour by hour, what happened, right? What led to the next thing, to the next thing, the next thing. And why is that important? Because usually when people have a recurrence, it's not usually like they think they have a craving and the recurrence happened, right? It's like they have a craving and there's like 6 things that happen that lead to the recurrence of the usage. And if we can understand what these links are, we may be able to replace them with things that are more adaptive that may have prevented that recurrence, or may have triggered a different behavior, right? So the chain would essentially split off into something more adaptive. So understanding these links can be really helpful. So this is an example of a template. You have it in the drive as well. But basically what you would ask yourself is, what is the major problem behavior that I'm analyzing? What prompting event in the environment started me on the chain to my problem behavior? What things in my environment myself made me vulnerable? So looking at vulnerabilities is something very important in DBT as well. And vulnerabilities can be anything from, not having eaten, not sleeping, not taking care of yourself, not managing stress, things like that. What is the function of my behavior? Why does it exist? And then you get into, how am I going to analyze my chain? And that's the movie part I was telling you about. So you go literally kind of event after the other to understand exactly what happened. It can be any type of link. It can be action, sensation, cognitions, events, feeling. And then you kind of, as you write them down, you figure out what could you have done different that would be more adaptive, if there would be one, right? What would it look like? So that's one visual way to look at it. In your drive, it looks like this. So we split it essentially in the middle. So do you say what actually happened? And what could you do different, or what kind of skills could you have used instead? Oops. And then the last page is more around kind of relapse prevention or kind of more planning forward. So it's about kind of reducing your vulnerabilities in the future. How can you prevent it from happening again? What could you do to repair, correct, or overcorrect the harm that may have occurred from the event? And kind of your deepest thoughts and feeling about the event that you wanted to share. So that's how the whole chain would be done. As you can see, it can be quite a lengthy process because you really want to be that detective and kind of break it down. So we're going to try to do a bit of it. It's not going to be as long as it would be in a full appointment, but we'll do our best to see what you can come up with. And you can pick any situation. I was going to pick why did I eat too much dessert at CSAM and see where I get. So, because that is definitely a problem. I don't know what time we're at here. What time? How much time do we have, Dr. Lamba?
I turned off my phone.
Oh, you turned off your phone. All right.
We have about 20 minutes left, probably, right? It's probably about 1:40, I think.
Anybody's got a time?
Yeah.
1:40? Okay.
Yeah.
So how about we give you guys about kind of 10 to 15 minutes to pick anything. It can be like, why did I eat this sandwich, to why did I leave this in the closet at home and did bring it with me? It doesn't matter. Pick something and just go through it. You can do it with someone if you prefer. You can do it by yourself. And then write maybe something that you've learned from this that we can debrief at the end. Okay?
Yeah.
And if you have any questions, let me know.
It's perfect for things that you regret, like things that you regret that you did that, and then it's really about getting that full timeline and course, and it's in the file. And we'll walk around a little bit as well because there's a couple of adaptations we do for addiction and stuff like that too. But we'll just walk around and we're gonna
So we'll let you get started, okay? But if you need any help, just flag us and we'll come find you.